Today we try to use a targeted therapy as first-line treatment in CLL for all patients who need first-line therapy. Chemoimmunotherapy is not recommended anymore. We have the option of time-limited treatment, that is venetoclax and obinutuzumab, or a BTK inhibitor combined with venetoclax, or continuous treatment with a BTK inhibitor. In patients with deletion 17p and or TP53 mutation, BTK inhibitors are approved and reimbursed and used for most patients. We know that time-limited treatments have a shorter progression-free survival and a shorter time to next treatment, but these are also options for these patients, especially in young patients who would like to be off therapy. We used the combination of a BTK inhibitor and venetoclax in first line, mostly in clinical studies, but we also treated some patients outside a clinical study after getting the approval of the insurance company. We used it especially in patients with unmutated immunoglobulin heavy chain genes. It is important that the patient tolerates a therapy and has few, if any, side effects. If you use a BTK inhibitor, patients have to take it from 15 cycles till long term, and that's not a short-term treatment when you can when you accept to have toxicities. And there are also some long-term toxicities as increased rate of hypertension or cardiac arrhythmias that may be difficult to treat or dangerous. And so ideal BTK inhibitors should be very well tolerated, and it should have also few interactions with other drugs. The combination that has been investigated most frequently is the combination of ibrutinib and venetoclax. We know that this combination is tolerated as similar as the single drugs. If you combine, sometimes there are more gastrointestinal symptoms, but usually patients will tolerate it. But nevertheless, we know that in the relapse setting, the more selective BTK inhibitors as acalabrutinib and zanubrutinib had less toxicities. So I anticipate that when there will be more data and approval for any of these combinations, the more selective BTK inhibitor will be the preferred partner of venetoclax in this setting. At the EHA, the SEQUOI study was presented, especially the arm D that tested the combination of zanubrutinib and venetoclax in patients with deletion 17p or TP53 mutation. We already have seen data in the relapse refractory setting that showed that the zanubrutinib was better tolerated and had a better efficacy in this patient subgroup than ibrutinib. And zanubrutinib as monotherapy showed also a good response rate and stable responses in the at 1 and 2 years. The combination is attractive, and in this study the duration of the combination was MRD driven. So patients who had confirmed MRD negativity could stop the treatment. The duration of venetoclax was between 12 and 24 months for every patient. The response rate to the combination was 100%, and the majority had complete responses, and more than half had a MRD negative response. And in the interim analysis, we saw that at 24 months, the progression-free survival was 94%. That's numerically higher than with zanubrutinib monotherapy, and also higher than with ibrutinib and venetoclax, although you shouldn't do comparisons with other phase 2 trials. So this combination seems to be very active also in this group of high-risk patients, and when it will be available, it will be one of the preferred treatments for this high-risk patient group.